welcome again to the course, the UCSF Mini Medical School course in geriatrics. And just to remind you, I'm Dr. Anna Chodos. I was our lecturer last week, and just wanted to introduce you to this evening's presentation. This evening is about staying social and the social impact, the health impact of staying social and connected to your community. So we're very lucky to have two presenters, Dr. Carla Perissinotto, who will present first, and Timothy Ryle, who's from the Institute on Aging Friendship Line. So once again, we'll have a dual presentation with different sides of the issue, staying social. So as we get started here this evening, I wanted to do a brief introduction of our speakers. We're really, really thrilled to have such wonderful colleagues here this evening. Dr. Carla Perissinotto is an associate professor in our geriatrics division, and she's truly what we call a triple threat: an educator, an incredible clinician, and a researcher. And all of those things have been to help older adults, but she's particularly known nationally for her work on the health impacts of loneliness, specifically loneliness. And some of you may have seen her recently quoted in the New York Times on an article about the epidemic of loneliness in older adults. That was last month. That was a really nice article. So she works clinically at Over 60s Health Center in our UCSF House Calls program. It's primary care for homebound older adults. And does an incredible amount of teaching at all levels, principally, though, with our residents and fellows in geriatrics. So again, we're really pleased to have her speaking tonight. And then next, I will bring up, when she's finished with her presentation, Mr. Timothy Ryle. And he's a volunteer coordinator for the Friendship Line at the Institute on Aging, which is here in San Francisco, but that's actually a nationally available resource, 24-hour resource. And he's currently majoring in gender studies and human sexuality. He's a graduate of the Sex Educator Training Program at the San Francisco Sex Information. And he's worked at the Department of Public Health and HIV prevention and drug rehabilitation research with minorities and older adults, and worked at the San Francisco VA, where he successfully recruited and created retention strategies for 2 different research studies on veterans with PTSD, post-traumatic stress syndrome. Thank you again, everyone. I'm going to welcome Carla Perissinotto, and as usual, we really appreciate your involvement and participation during the discussion. Thanks.
Thanks so much for having me, and it's great to see so many of you. And I should actually start by saying that it's actually fabulous that you asked for handouts. It makes me feel young, because when I teach to younger generations, they all think I'm very old by giving paper handouts, and they want it all electronically. So I think this is great. So thank you. So I'm hoping we can cover a couple different things today. We're going to start by just talking about a little bit broadly about the complexity of taking care of all of us as we get older. We'll talk a little bit about what it actually means to be lonely or socially isolated. We'll talk about the health effects of this. We'll think about who might be at risk for being lonely. Think about strategies of what we can all do to address loneliness and increase socialization. And Tim is going to help us at the end, especially talking about community program and what's available here in San Francisco. So I'm going to start by discussing 3 cases. So these are some folks that I've taken care of over the years. So the first thing is, this was in 2013, and I took care of a 94-year-old woman who died after deciding not to undergo cancer treatment. She had no family. She described her friends as professionals, meaning that they were their doctors. I was thankfully considered a friend among them, her attorneys and her caregivers. 1 week before she died, she actually told a friend that she felt very alone. So the question I have for you all is this woman isolated, or is she lonely? The second case is a person who is 102 years old. He ended up dying in the hospital because he didn't have enough help at home to really keep him at home in his last final months. He was homebound, so he was someone we cared for in our House Calls program, who takes care of people that can't get out to the doctor regularly. He had family out of state, but no one that really was able to visit him routinely. He had a visiting doctor. He had a very caring neighbor who always helped to check in on him and make sure he had what he needed. And he had maximum in-home support services hours. So this is a Medi-Cal benefit for people who are low income who need help staying at home. So he had the maximum hours, and despite that, he still had to die in the hospital. And so the question about him is he someone who might be lonely? And then last question is an 82-year-old woman who was actually pretty healthy. She had some arthritis that limited her life quite a bit in terms of her ability to get around. She had 4 children in the area, several grandchildren. She had 24-hour live-in help. She had frequent social engagements. And so the question about her, is she someone who could be lonely or even depressed? So I'm going to have you think about those cases as we move forward to try to contextualize what we're going to be talking about. So why should we focus on all of us as we get older? And why are older adults different than younger adults? And should we even care about loneliness or isolation? This is not something that we are routinely taught in medical school, so you're lucky in your mini medical school that you're learning about it. And the other question we get often is, isn't this all the same as depression? So why does this matter? I mean, we're sitting in a room here with people who are getting older, we all are, and we know that nationally, internationally, these are growing trends that we're all getting older and the younger populations aren't reproducing fast enough, myself included, to make up for the younger people to help take care of us all as we get older. And so what we're seeing is that actually there's been a 28% increase in the population over age 65 since 2004. And what's also really important to know is that once you reach age 65, there's still close to 20 years left of life expectancy. And this is something that's actually really important as we think about actually medical education. And I gave a lecture yesterday to medical students. And, you know, it's very funny when you talk to younger doctors and medical students because they'll write in the chart, older adult, and they're 50. And I'm like, come on, like that is not an older adult. And so it's trying to remind people that there's a big spectrum. And, you know, I generally see people who are over 80, so I'm like, you know, maybe then we're start calling you older, but there's a large variety, and again, this has to do with life expectancy and what we're really looking at. The other important thing about demographics is that a large proportion of the adults getting older are from underrepresented minority groups, so also shifts in demographics. Amongst gender differences, so women are more likely to live alone, and there's actually an article in the New York Times over the weekend looking at women specifically living alone and men being more likely to marry in later ages or remarry. So very interesting things that may affect some of these constructs. And then if you look at the older population, so those age over 85, this is one of the fastest growing populations as well. And this is probably one of my favorite groups of people to take care of is the older folks. So massive numbers, and really what's great for me, it means job security, but it also means that there's a lot that we need to learn in terms of how are we taking care of all of us as we get older, and what do we need to be thinking about differently. So what we know about older adults, so if we start first by thinking about younger adults and what the different things that affect someone's function or someone's ability to live independently. You think it can be what's going on medically in someone's life, so what illnesses they have, what's going on in the family and the social realm, is someone connected? What's going on cognitively? Are there any memory changes? Is there depression or other emotional disturbances? What's going on in the environment? Are there resources around, or someone is in an impoverished area? And financially. So in a younger person, these things intersect, but they don't quite, so they all intersect to affect someone's ability to live independently. But what happens when someone's older is that these circles really overlap so much that it's hard to really distinguish what's causing what. And so as a clinician, as a physician, I need to really understand what's going on in all these realms to make sure I can help someone stay independent. And that's why for this talk, this area of socialization and emotional state is really important, because they actually have a huge impact on someone's health and someone's independence. So what are we talking about? I want to briefly talk about some definitions of depression, because there can be overlap with loneliness and isolation, but making sure we understand these are different things. So an important thing to know is that depression is not a normal consequence of aging. It is common, but it is not normal, and it's important for all of us to know that. The prevalence, meaning how many people in this group experience it, anywhere from 1% to 50%, probably on the higher end, depending on the studies on how to measure it. And what it can also be due to are things that impact our grief, having poorer health, and then life transitions. So going from working to retirement, losing a spouse, losing a child, all those things really can impact depression. So there are some differences in terms of whether someone develops early onset or late onset depression. Early onset can mean that someone gets depression before they reach adult age. So this is someone who may have episodic or chronic or recurrent depression. And then there's a subset of people that for the first time they're experiencing depression later in life, and that is a different sort of thing that we're dealing with. So again, important to know that this is something we could be seeing. What's happening with, or what happens with depression in older adults is that it is very challenging to diagnose, to recognize. There are many medical problems that can appear very similarly. For example, someone could have untreated thyroid disease and it could manifest as depression. And then there's medication side effects that can overlap. You could be feeling tired, you could be feeling run down, and those could be medications. So it can be really tricky for us as clinicians or as patients to really figure out what's going on. And then lastly, I think I assume many of you have gone to the doctor and realized that unfortunately all clinicians are strapped for time and you're running around, and so there may not always feel like there's enough time to talk about this. And sadly, there's still a lot of stigma around mental health and the ability to talk about this. Other things that we see in older adults is that some older adults who are experiencing depression, they may not experience the typical symptoms, but instead they have a lot of somatic, or what we would call physical complaints. It could be back pain, it could be stomach pain, it could be vague things that actually are a manifestation of depression. So that's something that can be tricky. Other things, it may be that you're getting, as a consequence of this, you're getting standard medical therapy and you just aren't getting better. And it could be a sign that there's some untreated depression there. Other things that can happen less commonly, but still there, is memory problems is actually being a sign of depression. There's some very interesting research looking at depression potentially as a prodrome or a kind of a precursor to dementias. So there's some interesting work being done there, and we're still trying to tease this out. And lastly, there are some types of depression which present with psychosis, meaning delusion. So someone who's really just believing things that aren't there, seeing things, just disordered thinking, and that can actually be a sign of depression. So some very interesting things that happen there and hard to tease out. So who's at risk for depression? So certain medical illnesses are a huge risk. For example, stroke. Post-stroke is a very, very high risk period. Same thing with heart attacks. And then other illnesses that you wouldn't normally think about, so diabetes, cancer, and then Alzheimer's, dementia, again, is something where we're seeing some coexisting depression, and whether one is leading to the other, how they're interrelated, that's something we're trying to figure out. Risk factors for late onset depression, so being female, unfortunately, we have a greater risk. Being isolated, and this is where we'll get a little bit into the isolation issue. Marital status can have an impact, lower socioeconomic status, uncontrolled pain, so this is something we see a lot, uncontrolled pain and depression, insomnia, and then other evidence of memory impairments. Great question. Comorbid means two illnesses affecting someone, or more than one illness affecting someone. So the conclusion about depression is that it is actually pretty common in older adults. It can be undertreated and sometimes hard to recognize, and it can be hard to talk about in the doctor's office, but there can actually be effective treatment. So this is just a brief introduction. I don't mean this to be an entire lecture on depression, but I think it's important to contextualize and put this in the equation before we move on. So now let's talk about whether we're talking about loneliness or social isolation. So we know that here in the United States, we have about nationally 28% of people living alone who are over age 65. And then, as I stated earlier, pretty close to half of women who are over 75 live alone. So we'll talk a little bit about, living alone does not equate with being lonely, but there is a risk factor of being alone then developing loneliness, and we'll talk about that. In terms of the prevalence of loneliness in the United States, in a study that I conducted, we determined that about 43% of adults report feeling loneliness at some point. And other studies replicated around the world, which are actually showing similar numbers, probably around 30%, and it also depends on how we define it in severe lonely or somewhat lonely. So pretty significant burden, actually, of illness potentially, or a symptom that could actually lead to some health consequences. So how do we define loneliness? So loneliness is what we would say is the subjective feeling of being alone. So this is someone, I can't tell you if you feel lonely. You have to tell me, and that's something that you and yourself know, or I will talk to you about how we can look for that. But this is an important thing, because I have patients in my practice who I may have made assumptions before thinking that someone's lonely because they live alone or because they don't have family, but there's so much variability that it's really important to make that distinction that I can't say, yes, you're lonely. The other thing important about loneliness is that the word distress. So this is really the distress that someone might feel from what they want to have in relationships and what's actually happening, okay? Now, how this differs from social isolation is that social isolation usually refers to something that's more quantifiable, so numbers-based, in terms of how many relationships someone has, how frequently they have contacts. So there's different ways of looking at, but if you think about it, loneliness, is really about subjective feeling, how you feel, and isolation is about the number and quantity of relationships. I make a point of making these distinctions because there's quite a bit of work being done in the literature on loneliness and isolation, and often the terms are used interchangeably, and it's important to realize that while these things overlap, they actually represent different things, they measure different things, and we probably go about treating them or thinking about them in different ways. So another thing to think about between the distinction is that social isolation, so the actual numbers of relations, doesn't by itself account for the distress that someone's going to feel when they feel lonely. Okay. There's a fantastic group in the UK called the Campaign to End Loneliness, and one thing I liked is another way that they looked at looking at loneliness is factors that are within a person and outside of a person, or vice versa. So the different factors that could be affecting someone and whether they feel lonely are someone's personality traits. There are some folks that have always enjoyed being alone and they don't want to engage in other people, and that's okay. But for some people, that's going to affect their feelings of loneliness. The other thing is psychological response. How does someone deal with adversity and limited social relationships or loss of relationships? That could then impact whether someone feels lonely or not. Is someone a member of the social group? Do they want to be? Is that something that's changing over time? And there's other things, life events, traumas, and different things in someone's life can ultimately affect whether someone feels lonely. A couple myths about loneliness. It is not a normal part of aging, and I think that this is really important to talk about. Unfortunately, I think we have a long way to go in our country with ageism and how we look at older adults and whether we integrate all of us into the same community or whether we purposefully isolate people. The other thing, as I mentioned, and why I talked about depression, is that loneliness is not the same thing as depression. You can have both, but one doesn't mean the other. The other myth is that you can't be lonely if you live with other people. And this is very important, and I'll show you some data that shows that even when people live with other people, you can still experience loneliness. And I won't ask for a raise of hands, but this is something that we do experience. And then lastly, this is something about how we intervene, is that we cannot assume that loneliness is going to go away just by forcing someone to make a connection or just by forcing someone to go to a senior center. And that's really important because there's not going to be a one-size-fits-all, and we have to really think about how we target this. So who's at risk for loneliness? Unfortunately, women, I don't know what's going on with us, but women, we're at risk, more at risk than men are for loneliness. As we get older, we're at greater risk. Caregivers, so people who may be caring for another family member, are at risk, and a whole slew of other things. So this is all on your handout, so I'm going to move on a little bit, but there's certainly several risk factors for loneliness. Other things important to talk about specifically, and particularly important here in San Francisco because we have such a large population of LGBT older adults, is that there's an increase, potentially, or we think increased risk of loneliness in LGBT older adults because of feeling worried about disclosing sexual orientation to others and whether you can feel connected within a group, and the fear of being neglected. So how do we determine if someone feels lonely? So already I've said I can't tell you whether you are lonely or not, but there are actually some good questions that can help us tease away at this. So there was a scale that came out of UCLA, and it's called the 3-item loneliness questionnaire. And it asks 3 questions. It asks, do you feel left out? Do you feel isolated? And do you lack companionship? And if you notice, none of these actually use the word lonely. And it's similar to in depression screens, we don't ask someone if they feel depressed because it's trying to get out the underlying symptoms or feelings that someone might have. And the higher numbers that you get, so if you're more often feeling left out, isolated, and lacking companionship, the more likely you are to be lonely or to likely feel lonely. Okay? This scale has actually been validated pretty well, and so it's a great tool actually to use in medicine, and actually it's used in research as well to look at this idea of loneliness and the subjective feeling of feeling left out. So so the question is, how do you score it? So there's different cutoffs. Some would say a cutoff is around 6, meaning that at least some of the time you feel that you're feeling one of these symptoms, and the higher the score, the more likely that you're to feel more lonely. So how does the loneliness affect health? In 2012, with some of my colleagues here at UCSF, I conducted a study. It was in a national representative study out of the University of Michigan called the Health and Retirement Study. And this was looking at people over age 60. It was 1,600 participants. We followed people over 6 years, and they were asked if they were lonely using this questionnaire. And what we wanted to look at is whether people who felt lonely had a greater risk of death and whether they had a greater risk of losing function or losing their independence. Now, the reason why this was important to me is in my practice as a geriatrician and in the community and in seeing people at home, I had a feeling that there was something else affecting my patients' health that I wasn't traditionally looking at. So I measure blood pressure, I look at cholesterol, I look at all these things, but I felt like there was something missing. And so this is how I really got interested in loneliness. I was also very curious to know, how do we address this? Does loneliness improve or get worse if someone enters a nursing home? So that was really the idea behind this. And so this is what I started looking at. In terms of how we assessed function for our study, in geriatrics, how we assess function or someone's independence is based on something called the activities of daily living. This is whether someone's able to bathe, dress, toilet, transfer, and feed themselves. They seem like pretty basic things, but a lot of us can struggle with these things, as simple of having trouble bathing and putting our shoes on, and these ultimately can be a sign of our health status as well. The other thing we looked at is upper extremity tasks, so the ability to raise things above your arm, and decline in mobility, which was measured as the number of steps and ability to go upstairs, difficulty in climbing stairs. Other things we looked at, so this, I'm going to warn you, this is a really nerdy research slide, but the things, and this is something where we look at the other variables in the study. So we looked at how old people are, so the mean age was 70. We looked at We separated by age. We looked at their gender, ethnicity, and whether someone was married or partnered. Well, I'll call attention to here is that among people who were lonely, 62% of them were married. Okay? So this, again, is getting to our assumption about whether you can be married and lonely. And, many of us, I'm sure, have experienced it in different times of our life. But again, it says this is a complicated social construct, and we can't make assumptions about people. A couple other things here. So among people who were lonely, 26% lived alone. Pretty high number, but that actually means that the majority of people were living with other people again. So it's not just living alone that's going to make someone feel lonely. And again, this makes us re-question our assumptions about people. So what did we find? So we found that women were more lonely. So were non-white participants in the study. The participants who were more lonely were people who were slightly older, they had lower socioeconomic status, and importantly, the majority were not depressed. And again, this is an important thing. When I first started studying this, no one believed me and said, oh, you're just looking at depression, this is not that exciting. But actually, this is there can be overlap, but it's a different definition. And so these are people who are lonely and not actually depressed. So what did we find? So what we found is that over this 6-year period, people who were lonely were more likely to lose function, meaning they had a decrease in their activities of daily living, their ability to do their activities of daily living independently. The other thing we found is that there was a 50% greater risk of death in people who were lonely. So again, regardless or aside from when you take out these other things like depression and chronic medical conditions, loneliness by itself was a very significant risk factor for affecting someone's health and independence. So what we found from the study is that loneliness is pretty common. it is an independent predictor of functional decline, meaning that, as I said, when you control or take out the things that usually affect someone's health and their risk of death, like other medical conditions and depression, loneliness was still an important predictor. The other thing we know from this is that we still have so much to learn. This was just the start, and there's so many additional questions that we have in terms of why does this actually happen. And so that gets us to the potential mechanism. This is where we have a lot to learn. The challenge with some of these concepts like loneliness is that they're multifactorial. There's not an exact thing to say this is what causes it. And so it makes it very hard to study. Some research around the country shows that there's some postulation or some hypothesis that does loneliness lead to an increased stress response? The distress is so distressing that it's increased stress response, and that leads to other health outcomes, and that's how you have functional decline and death. There's other theories about having decreased sleep when you're lonely, decreased functioning of your limbs, and decreased engagement in the medical community. So different theories out there, but it's not exactly clear yet how exactly it's working, but we know that there's an association. So other results, these are some older studies, but literally every month this is a hot topic, both in terms of loneliness and social isolation. And you see a lot being written about this, not just in the medical literature, but we're seeing more in the New York Times and then the lay press about how loneliness and social socialization are affecting health. So this was a study that looked at actually cardiovascular risk and showed that people who lived alone had a higher risk of cardiovascular disease. And I'm just going to run through a couple things just to show you an example of what else is being written out there. So this was looking at loneliness rather than social isolation as a predictor of mortality in men. And this was linking loneliness and the risk of dementia. So quite a bit being going on here in the literature. And this study really looked at both people who were lonely and socially isolated, meaning someone was subjectively feeling alone, but they were also literally alone, and this showed greater mortality as well. So what does this all mean, and how can we put it together? We know that loneliness by itself increases morbidity, meaning the effect on someone's health. There can sometimes be depressive symptoms. There can also be changes in cognition or mental function. And ultimately, the important thing is the impaired function and the risk of losing independence and your risk of death. So bottom line, there's an interesting study that looked at comparatively, if you think about the risks of illnesses, loneliness can be, in terms of its increased risk on death, similarly to smoking 15 cigarettes a day. This is not causal, doesn't mean that it's an exact thing, but it helps you contextualize what a big issue this is and that it's under thought about and underappreciated in the medical community. So what's going on in the media? So this was one of my favorite articles that came out of India that said that loneliness can actually kill you. I think this is a little bit of an overstatement, but I do think that, it's a little bit of a big statement, but it actually is important to highlight that this isn't something that we can ignore, and it actually really is a public health concern. If you look around the world and in the United Kingdom is actually taking loneliness very seriously and have a massive campaign to try to address it. We are so far from that United States, but I'm hoping that we will get there. And then this other one was, kind of making everyone feel guilty about not calling their family members by reading my study. So I don't know if that's a good or bad thing. But I think, what I appreciate about some of these studies and being written about it in the public is that it's bringing awareness to all of us as that we get older, that we can't be ignored, and that there's actually an important thing about social connection and how we talk to each other's family members and friends. A couple years ago, Oprah had a very brief campaign about just saying hello to people and using that as a way to combat loneliness. Maybe a little bit simplistically, but I think the message is still there, that actually acknowledging that we are in the world together and actually making contact with people and saying hello can have a bigger impact than you think. I've walked down the street and said hi to someone who I can tell no one has said hi to in a while, and it's this look of shock that you actually acknowledged me, and it's a nice response when someone's like, oh, hello, so it's a good reminder to us all. So potential interventions. So I would say one of the first things is asking about loneliness or thinking about loneliness, whether it's in ourselves or people around us, or if we're working with other people, to think about that. This was a great quote by one of a fabulous jazz musician who lives in the East Bay, and one of the things she says, and you can read it here: if you want to avoid feeling irrelevancy, you need to maintain your friendships, maintain your family ties, stay an active part of other people's lives in whatever way you can. So this way of staying active and connected is going to vary for each person. Not everyone has family, and that's okay, but there's different ways of staying connected, and connectedness means different things to different people, and that ultimately is where we need to go. I can't give you a prescription exactly for what you're going to need unless we talk and figure out what's important to you, but it's starting the conversation that has a big impact. Nationally, as I said, or internationally, the United Kingdom has a fabulous program with great resources called the Campaign to End Loneliness. And again, I think they're seeing these health effects, and they're starting to look at this at a global level, at a public health level. The second thing I would say, in addition to asking, is talking to healthcare providers about loneliness. Okay, so I know that sometimes as healthcare providers, as I said, we're often strapped and feel like we don't have enough time, but actually bringing this awareness, the more we bring this up to with our healthcare providers, the more we bring awareness, I think it'll again raise the bar and show that this is an important thing to consider in someone's health. We get so focused on traditional risk factors, and when we ignore these things, we're missing a big part of the puzzle. So in terms of the management and bringing this up with healthcare providers, it can be complex. And again, because the way that people become lonely and the way we experience connection can vary from person to person. But there's different ways we're trying to conceptualize loneliness, and I don't have all the right answers here. We're going to talk about some community programs coming up, but some of the ideas that we think about in terms of what can be affecting loneliness and how can we affect it is, are there a way to improve people's social skills? Is there a way to enhance social support and increase the feelings of connection with one person? Increasing social support or just the opportunity for connections, and I think that's something that my colleague Tim will talk about. And then this addressing maladaptive social cognition, that's kind of a fancy term, but it's really thinking about how do we adapt to the changing roles that we have in our life and in society. So what can we all do to think about how we engage and how we can engage with our community to maintain our health? So thinking about what's important to you. How can the people around you support you to live an active and healthy life? And if you don't immediately have people around you, how do we reach out to you and how do we identify people that don't have that so we can help them increase their selection? What did you used to enjoy doing? Is there a way to work on that? Is there a way to participate with family interactions? Now, again, this is going to vary from person to person. I tell this story often, but I took care of a woman who was lovely, who made me feel like an idiot because here I was writing about and talking about loneliness, and I never asked her. And I felt so bad the day she came to see me, and she said, Dr. Parasinotto, I feel pretty lonely. And I'm like, oh my God, I can't believe I didn't ask you. But I was very thankful that she actually brought it up with me. And so we spent a while talking about what would be helpful for her. She didn't have family in this country, and that was very challenging for her. But she told me that she used to love working in retail when she was younger. And so she actually had an opportunity. We brainstormed, and she actually ended up volunteering at a Salvation Army, and it was like life-changing for her. And I couldn't have come up with that. I mean, that's not usually in my bag of tricks, like go volunteer at the Salvation Army, but that really worked for her. I have another gentleman who's suffering from visual impairment, and so we've been talking about different ways to get him connected because he can't see anymore. And so one of the things we've been talking about is books on tape so that he can participate in book clubs. And there's something called the Senior Center Without Walls, which is phone-based support, which is great for people who can't see and who can't get out. So there's not a one-size-fits-all approach, but it's really having the conversation about what's meaningful for you and how can we get you back into that area where you feel like you have a connection with someone and some other people. So utilizing existing community programs. So Patrick Arbor, who is one of the founders of, or the founder of the Friendship Line at the Institute on Aging, he has this beautiful quote, and he says, "It's about reminding people that they are still a part of their community. We work to encourage caring connections because that is what binds us to life." And that, in sum, is what the Institute of Aging does, and I think that, in sum, is also what we need to think about as we move forward to really focus on how we can stay healthy and connected. Other community resources, this is a little wait. We will hear about this, which is exciting, but some potential outcomes. So what does it actually mean to participate in some of these programs? So at John Muir across the bay, they have this program called Caring Hands, and they actually have really thought about, is this a program that can help with loneliness? And it's a program that actually helps connect people who are members of the John Muir Health System with volunteers who can drive them to appointments and help with various other things. And there was one woman who was 75, so pretty young, who was a widow and a participant in the program. She had a lot of difficulty getting out to go grocery shopping and getting to her appointments. And because of this limited mobility, this really left her feeling isolated, and she felt very lonely. She now has a weekly visitor, and she gets rides to her appointments. And what she said about the program is that she said, "You have saved my life on more than one occasion." And I think this is a pretty literal statement, but it really saving her life by getting her connected to her medical community, but having that one-on-one connection. So this is, I think, one example of what we can actually do to affect change and affect someone's health. It's one example, but I think it's pretty powerful and an indication of where we need to go with research to understand what can we actually do about this. So what lies ahead for all of us? So funding. So it's actually pretty sad and disconcerting to me how difficult it has been to get research on loneliness. So there's a lot being done, but in terms of actually looking at intervention and what works, it's been quite challenging. And so that's something that for myself as a researcher, I'm constantly trying to figure out how can I get people to support my work so we actually know what works. There's a lot of programs out there, but how can we say this one actually works? And actually, spoiler alert, but I'm working or trying to work with the Friendship Line on studying it as an intervention so that we can show funders and say, hey, this actually really works. We have anecdotal evidence. We know, we see people firsthand. We hear these stories, but we need to make it global and a bigger scale so we can expand this to other communities. So understanding which interventions work, and we can't do that without knowing what's out there and studying it. And spreading the word about the importance of all this as a public health problem and the need for more research in this area. I'll also say that the importance of looking after ourselves and each other. It's, I'm humbled all the time in my job when I hear people telling me about this, and it's a reminder to ask about these things. And again, I saw a gentleman today, like I said, who was visually impaired, and we started really delving into this idea of loneliness for him and the fact that he was a very accomplished gentleman, now can't see, and it's been completely life-changing for him. And so that's something that we're constantly looking at. So let's revisit the 3 cases as we end. So we have the 93-year-old woman with squamous cells. She had cancer who decided not to go treatment. So what was interesting about her is that she, in her last days, despite being surrounded by what she said professionals and people checking in on her all the time, she was lonely, but she wasn't isolated. She had everything around her, but she still felt lonely. And so this helps us recheck and think about, what are we missing? And the other thing is that she wasn't lonely when she was in her own home, but it was lonely once she had to move to a skilled nursing facility. So that was very interesting to me, too, is that she actually had more people around her, but it was devastating for her, and that was not the right thing. And it really, unfortunately, led to her decline, and that was a hard thing for her. Now, the 102-year-old gentleman, so he was not lonely, but he was pretty isolated. So even though he had myself as the doctor going to see him, he didn't have a lot of support because he was really stuck in his home. So he was pretty isolated, and that was very hard for him. And then we have an 82-year-old woman who was pretty wealthy, who had 24-hour care and had multiple family members, and despite all that, she felt incredibly lonely. Okay. So this is very different cases, very different socioeconomic statuses, genders, and race, ethnicity, but all of them had these effects. And my question, or my thought, is that these feelings of loneliness or the experience of isolation actually really ultimately impacted their health. So let's review what we've learned. There will be no test. I hope I've helped you recognize, or you may all be experiencing, or some of you may explain that it's complicated to get older. My dad is 74, and he's like, this is not easy. And when I tell my mom she still has another 20 years life expectancy, she's like, no, thank you. So, but it varies from person to person what they want, whether longevity and how someone values life. So it's important to think about how complex it is. I hope I've helped you distinguish and think about loneliness and isolation, how they differ, but how they can overlap. And I hope I've taught you how to look for loneliness and think about how we think about that's a funny statement, but how we conceptualize loneliness and how we can actually screen for it in medicine or even in our own communities. I hope I've described how loneliness can affect our health, which ultimately means that by combating loneliness, we hope to have a positive effect on health. And I've introduced you a little bit to community programs, but we're going to talk a little bit more with Tim about what actually is out there in our community to help with this problem. So to drill it in a little bit more, which is what we do in medical school, is repetition, is loneliness is incredibly common. It can be much more distressing than the things that as doctors usually talk about, which are hypertension and all this other stuff, but that actually may be what worrying some folks more than other things. We can actually make a difference by starting to talk openly about this, and I firmly believe this. From the first studies, or when my paper came out, and my study came out in 2012, it's not because of my research, but I think that it's really fascinating and great to see that more people are talking about this, and I think that this is starting to change the tide on how important whether we see this as an important public health problem. And then I hope I've introduced you to the idea that there are some programs in the community and some opportunities that may be a benefit to some folks. Thank you.
Thank you, Carla. And as always, it's really inspiring just to hear your passion for this topic and for helping older adults. So everyone, just want to switch gears a little bit to an actual intervention and resource for us. So Mr. Ryle, again, thank you so much for coming to talk about the Friendship Line.
Thank you. I'm very excited to be here, so thank you for having me. So my name is Timothy Ryle. I'm the volunteer coordinator with the Friendship Line at Institute on Aging. And I thought I would start with telling you first a little bit about what the Institute on Aging is, if maybe you don't know a little bit about it. So I'll tell you more. And I'll start with our mission statement. So basically, this is a lot, but the essential mission statement is to help older adults live more independently and safely in the confines of where they call home, wherever that may be. And we've actually been doing that since 1985, when we were founded by Dr. Lawrence Feigenbaum. He was a physician at Mount Zion Hospital, and he saw older adults come to Mount Zion Hospital and then be sort of, pushed away into nursing care facilities. And he saw that that was actually not maybe the best thing for many of the patients that came through, because they were removed from their family, their friends, familiar surroundings, and also social activities. So he wanted to create something that sort of helped older adults. And so that's why he created the Institute on Aging. And since then, we've actually expanded our focus, so we're no longer just for older adults. We're also for adults living with a disability and also their caregivers. And also we've expanded where people can access our services. So we're not only in San Francisco, we're now in Sacramento, Marin, San Mateo, Contra Costa, Alameda, and also Santa Clara. And we host a range of different services at the Institute on Aging. And I'm going to briefly go over some of them, but for the most of the time that I'm up here, I'm going to talk more importantly about the Friendship Line. But I'll start with some of our services. So we offer home care and support services, basically personalized care, whether that's companionship, if someone needs hourly or 24-hour, 7 days a week care, or overnight assistance, dementia or Alzheimer's care. We can specialize in that. Home safety evaluations, meal planning and preparation, escorted transportation errands, or maybe you just need someone to go with you to the grocery store, and also some light housekeeping. We also provide social day programs. And this is where we actually will pick up older adults from their homes and we'll bring them to our facilities to participate in group exercise or intellectual stimulation. artistic expression, creativity, so music, games, etc. And then some other personalized daily care. We'll also provide a meal for them. And some of our clients, may need some additional assistance, whether that's, going to the bathroom or helping walk, or also helping to eat. So we can help with that during our social day programs as well. And then there's our all-inclusive care. And that's, as it states, all-inclusive, where you can get medical, specialty care, social services, transportation, all of the therapies, if you will, home care and personal care, nutritional services, nursing care, adult day health care, and prescription drugs. And then there's our community living services, which is basically where we assist people with a limited income to help transition from the nursing homes back into the place that they call home. So we'll help with, finding stable housing, access to community resources, and also reliable healthcare services. And then obviously we're the Institute on Aging, so we provide education and training, not just for our staff, but also for students, and we offer education credits. And then the counseling and psychology services, where we offer in-home or outpatient psychotherapy, so coaching, therapy, and also our grief-related services, where we offer 8-week individual or monthly traumatic loss grief group, and then Saturday morning drop-in grief groups as well. And then our Center for Elderly Suicide Prevention, which houses the Friendship Line, which I will talk more about. But those are kind of a very fast, brief overlay of the services we offer. If you had any questions that were specific to those services, I actually recommend you call the Connect call center at Institute on Aging, and they can further talk about some of the different services that we provide. But now I'd like to transition into the Friendship Line. And start with aging, because that's really, aging and loneliness is what we're talking about. And so we all know that aging affects everyone. There's nothing we can do. There's no cream. There's no pill. Everyone is looked. It doesn't exist. And so what happens as we age? And so there's lots of cultural factors. So there's a biological change, physical generation. We get wrinkles. Our bones become a little bit more feeble. That then may cause some chronic pain. Also, an average, older adults take an average of 7 different pain medications. And that can have an effect on us, obviously. And then there's a social aspect to getting older as well. Transportation limitations. As we age, maybe it's harder to see, so we can't drive at night like we used to. Or maybe it's harder to walk around, and so we don't get to go to the places that we used to go to. And so that makes our support networks dwindle. And then there's a psychological change, a loss of autonomy. There's the feeling of being a burden because you have to rely maybe on family or friends to achieve certain things that you didn't used to have to do. And these all kind of create loneliness for a lot of people. Some statistics that probably go with Carla's presentation. 28% of Americans over 65 have lived alone. That was from 2010. I imagine that number is higher, especially with the baby boom. Also, slightly more than 1 in 3 adults over age 45 state that they are chronically lonely. We also know that major depression plays a pivotal role in facilitating suicide. So it's approximately 60% of all cases of suicide, but it's 83% in elderly suicides. So it's much higher in older adults. You may or may not know this, but the elderly actually have the highest rate of suicide for any age population. And that's an average of 16 suicides per day. And more than half of those who commit suicide suffer from depression or loneliness. It's also, I kind of think it's important to note that over the age of 65, adults who commit suicide, the ratio is 1 suicide for every 4 attempts. And to put that into a little bit of perspective, for younger adults, it's the ratio of 1 for every 200 attempts. So older adults are much more successful also in committing suicide. Which is alarming. Also, statistically, white men over the age of 85 are the greatest risk of suicide. And elderly, as you saw from that earlier statistic, that they're more likely to use lethal methods, whether that's firearms, poison, medications, et cetera. And also, I think it's important to note that 70% of elderly people who commit suicide have seen their family doctors within a month before their death. So as Carla kind of mentioned, there's not a discussion with a doctor and patient about loneliness, as you talked about. And so this kind of is a graph. It's a little funny, but it just shows from 2014 the suicide rates. And again, I think media likes to talk that suicide rates are, most prevalent or highest among younger adults, but it is older adults. And you can see that individuals 45 to 65, and then also older adults ages 85 and above are more prone to suicide. So on this depressive note, there is good news. We are trying to do things to mitigate these numbers and to help older adults. And there are many different ways to do it. What Institute on Aging is doing is we have, not only do we have our services, but we also have the Friendship Line, which is a 24-hour, 7 days a week, fully accredited crisis hotline and warm line that is specifically for older adults and also people living with a disability and their caregivers. A lot of people don't know what the definition of a warm line is. But a hotline represents an emergency or a crisis call, and a warm line represents a non-emergency emotional support call. That is the majority of the calls that come into our call center. A little bit about the history of the Friendship Line. So we were founded, as Dr. Carla said, by Dr. Patrick Arbor in 1973. He was very much aware that older adults are often ignored, isolated, and depressed, and that there's not a lot of people advocating for them. And so he wanted to do that. So he started the Friendship Line, and then it joined Institute on Aging in 1995. And as recently as 2012, we became accredited by the American Association of Suicidology. Who calls the Friendship Line? So we get a lot of calls. We get about 8,000 calls a month, a little under 300 a day. And we're nationwide, so while most of our calls come from the Bay Area, we get calls from 54 different counties in California and 38 different states. So what does the Friendship Line provide? So mainly we provide emotional support, reassurance, information and referrals, elder abuse prevention, and also crisis intervention. One thing that's really unique about the Friendship Line compared to other call centers is that in addition to receiving calls, we also make outgoing emotional support calls to individuals in need. So for whatever reason, if it's difficult for someone to call us, we will call them, whether it's every day or 2 to 3 times a week. Also, I want to talk a little bit about the types of calls that we get. So as I mentioned, majority of the calls are of a warm line nature. So of those 8,000 calls that we receive, I bet approximately 10 are actually active suicidal calls. And I think that that's for a couple of reasons. One, I think it's because of the name. We're called the Friendship Line. We're not called a suicide prevention line. And so people are more apt to call us who just want to talk, who are feeling lonely or isolated. Also, it's, I think, because we also allow our callers to call us on a daily basis. In fact, we encourage them to do so. And so they're getting emotional support on a daily basis, and they have something to look forward to. They, after speaking to someone in the call center, I always like to talk to them and then encourage them to call back the next day, and they always say, "Oh yeah, I can't wait, I look forward to it." So we're definitely building a rapport with many of our callers. Want to talk briefly about who answers the calls. This is a bit of a plug, if you will, because ideally we are run by volunteers. Volunteers are the heart of the Friendship Line. They're the ones that are really answering all of the calls. And so maybe you are interested in volunteering, or you know someone that would like to volunteer. And if you are, you would be providing that emotional support, that reassurance, those well-being checks, information, referrals, and also that crisis intervention and also elder abuse prevention, because all volunteers at the Friendship Line are actually mandated reporters. So if we do get a call from someone who is being physically abused or taken advantage of financially, we must report that to Adult Protective Services. And you must think, or you may think, that someone to volunteer here must have a lot of background in providing services such as these, but you don't. We actually will provide all of the experience that you need. And our training is actually, it's really informative. It provides information on ageism, cultural competency, active listening, which is a really important component in a call center. Also elder abuse, suicide risk. So it's not things that you will just use in our call center. It's information that you can take with yourselves on whatever you go to do. You'll also do some observations of our call centers. And so you'll get a chance to listen in on the calls and how our current volunteers handle those calls. And also there are continued lectures and trainings that you can be a part of as well. But why volunteer? Why should you volunteer? Because it's fun, because you actually can see the difference in the person's life that you're talking to. I can't tell you how many times I'm on the phone with someone, and in the beginning of the conversation, they're crying. And by the end of that 10-minute conversation, they're laughing. And that is why I come to work. It's a really beautiful thing. And so you will see that change that you're making in people's lives. You'll also get to meet new people. If the social component is really important to you, that's definitely here at the Friendship Line. We host sporadic monthly popcorn and movie nights where you can bring friends to IOA and talk. Also, we offer weekly in-house yoga. Self-care is something that is really important, not just to our callers, but also our volunteers. And so we offer that as well as yearly appreciation events, local discounts, and if you're in schooling, we're happy to provide any letters of recommendation. In addition to volunteering at the Friendship Line, there are other volunteer opportunities at Institute on Aging. Maybe the Friendship Line is too much of a commitment for you. You can also volunteer in one of our social day programs where you're actually having that direct one-on-one contact with someone. Volunteering, as we found out earlier, is a really great way to fight off loneliness and depression. And there are other volunteer opportunities as well. So thank you.